And we have people, these yesterday's from the casualty department, the Pelinomi, and we've got people from internal medicine, Dr. Sheldon Willemse and Mariette Armse and Warren Grant, and then we have radiology on board, which is really, we cannot work without a radiologist on our team. So we sit once a month, we have a meeting and we try to strike ID levels to streamline things, and we're getting there slowly. In the past, stroke was not a treatable condition. You could not, but I think maybe I'm jumping the gun. We'll get to the questions. But the fact is we have to work together to get stroke management to be better. And that includes from you guys, people that have to recognize the stroke and call the emergency services, then the emergency services, the nursing personnel, the radiologists, the internal medicine doctors, the consultants, everybody, and the nursing staff, of course, is really also very important. It's a team effort.
Dr. Smith, it's okay, don't worry. Ladies and gents, you did say I'm audible most without the mic, ne? Yes. These things happen, please don't be shy. All right. I think just for the people right at the back. Yeah, I'll still use the mic for the people at the back. All right, so I guess we'll just interchange for the session. Dr. Smith, you mentioned that, it's a work group. But now, let's say one of the people in the audience wants to know, how can they possibly be a part of it if there's any chance that they can be a part of it? Are there any opportunities for that?
I think the most important thing is to be aware of how it looks when somebody has a stroke and which number you should call when this happens. And we will talk about that. Being aware. And then there's another program that they call the FAST Heroes program. The FAST stands for face, arm, speech, and time. That is how they teach preschoolers to recognize a stroke, because your face starts to hang down suddenly, your arm gets weak, you speak differently. So they have a program that they call the FAST Heroes program, where preschoolers learn how to recognize a stroke. And they have games that they play and so I think if I can enhance that or advertise that, the people go to their schools where their children are and ask the teachers, can you contact the FAST Heroes program? Her name is Renata van der Merwe, and she comes to the school and she trains the teachers that train the children. And these children are often with their grandparents, and they are taught to recognize the grandparent that has a stroke. And the grandparents, of course, learn from them and then know when your husband had a stroke and know what to do after that. That's the best I think we can do today.
And I love that you mentioned that they actually teach the children, because how many of you know that, we're always so focused on older people, but we leave the children out of it, whereas we forget that children actually are like sponges. They take information in very quickly and it stays there. So it's very good work that you're doing with that work group. Now we're actually going to get into the conversation of the day. But with that being said, I'd just like to pose the question then, what is a stroke and why is it so important to recognize it immediately, and how can you get help as quickly as possible?
So first of all, stroke is a medical emergency. So it's not something that we can wait on. As soon as you think you've got symptoms of a stroke, you need to go and get help. So basically what a stroke is, we know that the brain gets a lot of blood. Every time your heart pumps, your brain gets blood. And the moment you cut off the blood supply to a certain region of the brain, that area where you've cut off the blood supply just doesn't work very well. And it's very important that we have billions of neurons, but when you cut off the blood supply, 2 million neurons die every minute. So every minute that you don't treat the stroke, 2 million neurons or brain cells are dying. So There are many ways in which blood can be cut off, either in through the blood vessel, you have a little clot that sits there and the blood can't flow, or the blood vessel basically, we say, ruptures or it pops and the blood seeps out. And both of these two mechanisms can cause a stroke. But the very important thing is the time-sensitive nature. We have 4.5 hours to do something once the stroke has started. So after 4.5 hours, we can't give you the treatment that we have available to try and reverse the effects of the stroke. So that's why it's so important to understand how time-sensitive this problem is. So stroke basically is reduced blood supply to a certain region of the brain. And we want to re-establish that blood supply. And that's how the treatment works. So I hope that answers the question of what is a stroke.
And it sounds very high risk, because you're mentioning now that you only have 4 hours to do something about it. But what then are the risk factors involved?
So age is the highest risk factor for stroke. The older we get, the more likely we are to have stroke. And then I use the A, B, C, D, and E acronym. So A is for age, B is for blood pressure. To check your blood pressure at your general practitioner is really important, because most of these patients have high blood pressure for a long time and untreated blood pressure. C is for cholesterol, D is for diabetes, and E is for environmental factors, like if you smoke or you take excessive amounts of alcohol, you are at a higher risk of getting a stroke. Now, A is for age, and most people that are coming with a stroke are old. But young people are also susceptible to strokes because often of poor lifestyle choices. People that are on their phone the whole day and don't exercise, or they smoke, or they take too much alcohol. Young ladies who have migraine with aura and smoke and take oral contraceptives are at a very high risk of having a stroke. So young people are not free of strokes.
I love that you cleared that out, because there's a general misconception that strokes actually attack much older people. So thank you so much for making it clear that even young people. But can you say like what age exactly?
Well, children can also have strokes, but we see young adults. The last patient we had with a cerebral stroke, she was 30-something. Yeah.
Let's say now I see someone having a stroke. What do I then do immediately? What do I do in that moment? What are the signs and what do I do?
So there's a mnemonic, as was previously mentioned, called the FAST mnemonic. So it's very important to remember this. It's facial asymmetry. So if you see someone's face suddenly starting to droop, you really need to think this patient could be having or person could be having a stroke. The other thing is arm weakness is the other one. The arm becomes weak. S stands for slurred speech, so they're all of a sudden starting to slur their words. And T is time. So the symptoms of a stroke happens very quickly. It's not something that occurs over days or weeks. It happens immediately. So if you see any of those symptoms, and they've sort of extended it to say, be fast. So if someone all of a sudden has balance abnormalities, they're walking and all of a sudden he's off balance, and also eye abnormalities, you suddenly can't see from one eye. So if you see any of these be fast symptoms, you really need to be aware that this person could be having a stroke and all these neurons are starting to die. So it's not something that you go and sleep off. If you recognize these symptoms, you immediately have to call an ambulance. The big problem that we've seen with some of these symptoms is that you don't have any pain when this happens. So a lot of people think, it will get better. And it oftentimes doesn't. So even though you're not having pain while you're having these symptoms, these BFAR symptoms, you have to call an ambulance and get to an emergency center ASAP. It's not something that you can, it's something that you have to act on immediately. So calling an ambulance, getting to an emergency center as quickly as possible that you can receive this treatment. Okay, so the number to dial is 112. So if you need to call an ambulance, 112 is the number, and call in, please.
All right, Dr. Long, I also have a question for you, especially along the lines of neurology. Can you perhaps paint a picture of the brain and what exactly happens in the brain of someone who is suffering from a stroke?
Okay, so the brain has got extensive blood supply, but there are basically, let's say, 3 big arteries that go in and supply the brain. And the most common one is the middle one. So you have an anterior, the front, posterior, back, and a middle artery. That is probably the most common artery that has a problem when you have a stroke. And this is the one, as I said, usually what happens is you have a little blood clot, and that blood clot can come from anywhere. It can come from the heart, can come from the neck, can actually come from the vessel itself. And this blood clot goes and basically just occludes the vessel. So everything higher up from that blood clot does not get any blood. And this is the part of the brain that ends up dying during the process of a stroke. So, yeah, I don't think, anatomy-wise, I think that's the main crux.
Dr. Smith, would you like to share anything about radiology, like in terms of how that looks?
That is Dr. Denson's forte. How it looks on the scan. Okay, so as we've all heard now, timing is very important. When immediately right after this happens that Dr. Long has described now, we usually do a CT scan. So you might have recognized this if you haven't had a CT scan yourself yet. You might have seen it on television. It's that round tunnel, and it makes use of X-ray technology, and it gives us nice cross-sectional images through the brain. Basically, if you imagine a polony that you slice up in thin slices, it gives us those kind of pictures of your brain. Now, immediately after this process has happened, we don't see anything, because although the process is happening, there's not any changes on our images yet. But with time, you can see some swelling, and we might even see some bleeding in certain cases. So the important thing is that the timing of when you had the stroke and when we actually do the CT scan is very important to us.
All right, let's talk preventative measures now. What are the secondary preventative measures of a stroke?
So I just like to say that we do the CT scan in the acute phase so that we can exclude a bleed. Because what we do with the treatment is we put a clot dissolver in the drip, and we run it in, and often the clot dissolves with this treatment. The faster you give this treatment, the better it works. So the longer you wait, the less your chances are that it's going to work. And after 4.5 hours, we cannot leave it, because if you do that, then you bleed into the stroke. The other name for stroke is an infarct. So you bleed into the infarct, and then you make the patient worse, and the patient might die. So after 4.5 hours, the time is up. So we can't distinguish clinically between an ischemic stroke and a hemorrhagic stroke. Ischemic is where the blood vessel closes and that area doesn't get oxygen. Hemorrhagic is where it pops and it bleeds. So 85% of them are ischemic. But we cannot distinguish clinically between an ischemic stroke and a hemorrhagic stroke. We need the CT scan for that. Because if we see a bleed on the CT scan, we cannot give that treatment. It's called out of place.
Now, for someone, let's say, who's here and they've got family that is family members who've suffered from a stroke, and let's say they were late, and unfortunately now, I saw also there's also the risk of, if you were too late, obviously, the risk of being left and you're, I don't want to say, is it paralysis? Disabled, yes. How does the family now support someone suffering from a stroke?
Well, the biggest difference that we've got 3 modalities that make a difference to stroke once you've had a stroke. The first is the clot dissolver, called alteplase. So the second one is where we call it the thrombectomy, where somebody goes, usually a radiologist, an interventional vascular radiologist, they go in the groin, in the blood vessel, and they have a clot extractor. They put I don't really know how it works, but they put a mechanism through the clot and they extract the clot from where it sits. It works for large vessel occlusions. You can think that you can't, you will not, the risk of doing it in a small blood vessel is bigger, but in a big blood vessel you've got a lot to lose if you don't do it. So that's the second thing we have. And the third thing we have is stroke units. A stroke unit is not an ICU. It is a 4-bedroom in a normal ward where there's a dedicated system and monitors where we can look after our patients carefully. And what we can do in the acute phase, if somebody's missed the thrombolytic window, that's that 4.5 hours, thrombolysis is where we dissolve the clot. So if somebody's missed that time frame, then we can put them in a stroke unit, and that makes a big difference to their outcome. There's an area in the brain that is called the ischemic penumbra. That is an area in the brain that is electrically silent. It's not dead tissue, but it's not normal tissue. And if we treat the patient correctly, we give them the right fluid, and we keep them cool. Somebody who's had a stroke must not have a fever. They do worse. We don't bring the blood pressure down too fast, because if we do that, we take away the perfusion of the brain. There's lots of, and we keep the patient glucose normal. We also give them oxygen if their oxygen saturation is less than 95%. So those things make a big difference to strokes. And we recover that ischemic penumbra, then becomes normal tissue if we treat the patient correctly.
And are there any lifestyle changes that need to take place? I would think most probably there are they?
Of course, I think it's human nature not to take the lazy route until something happens to you. Okay? So unless you get a stroke or a heart attack, it's the same pathology. Heart attacks and strokes, they're the same blood vessel disease. But heart attacks are painful, so people go to the hospital. Brain attacks or strokes are not painful, so people wait, and that's the wrong thing to do. If something happens, go to the nearest hospital with a CT scan. At the moment, that's not national hospital.
I'm going to open now to the floor for questions. Remember, I did say that you need to note your questions down if you have any. So my mic will be, if I can just get one person to please take this mic to me for the floating microphone. Thank you. Okay, is there anyone with questions? Please raise your hand so that we can give you the mic and you can ask any of our panelists the question. Any questions? Okay, there's a question right over there.
Thank you so much. My question is, why the solution for the stroke is 4 hours, 1.5? Is it because of the medication, or I just want to know why the solution for it is only for 4 hours?
Okay. So initially they did studies, and the first time span that they tested and did studies on was 3 hours. So they saw if you give it early enough, within 3 hours, strokes get better. Then they tested the boundaries and said, let's do it at 4.5 hours. And said, okay, but it still works. The complications of bleeds are much smaller than patients getting better. So if you give alteplase to 100 people, about 20 of them will get better. The big majority will not have any change, and about 2 of them will bleed. Then they tested, so if 4.5 hours is okay, why don't we make it 6 hours? And then they saw that people bleed if we make it longer than 4.5 hours. So it was study related.
Any other questions? Where's the shine? Okay, there's a question right over there.
Question for Dr. Radiologist. Sorry, I have to get his name. Okay, so you said you do a CT scan, but only after a while. But within 4.5 hours, treatment must have begun. So what time is your CT scan within the 4.5 hours or only after that?
Okay, so time is clearly the most important thing here. So definitely in our unit, but in most radiology practices everywhere, it's convention that there is a stroke protocol, and all patients who enter your radiology department with a possible stroke diagnosis gets prioritized. So we try to get them on the CT scanner as soon as possible so that we can scan them and give immediate feedback to the treating neurologists and tell them whether there is actually a bleed or not. Because if there's no bleed, they can immediately continue with their treatment if there's no other contraindications. So basically as soon as possible, that's what we try. We don't want to waste time to take x-rays of stable ankle sprains while someone's brain is dying.
One last question, colleagues.
Thank you. So I heard you spoke about treatment. So in the case whereby it's somebody that is not taking contraceptives but is exercising, does not have high blood pressure, now how do you ensure that at least you take precautionary measures? Is there a way, or when you go to the doctor, is there a way in which you can go and say, okay, I came to check in terms of my health if I don't have any symptoms related to stroke? Because at one point, you'd find there's a symptom that says sometimes the side of your body goes numb. So if it's not such cases whereby you don't experience any symptoms, how do you now take precautionary measures in that sense?
So if you're a young lady and you have migraine with aura, so migraine with aura means you get a throbbing headache on the one side, and before the time you get these flickers, then you should not take oral contraceptives and you should not smoke. So, yes, I think if you have a general healthy lifestyle and you go to your general practitioner once a year and have your blood pressure checked and have your glucose checked and maybe your cholesterol. Sometimes we're unaware cholesterol is not something that we feel. Sometimes we're unaware and that can be treated and it will protect your blood vessels. Hypertension is the biggest problem that we have. It's also mostly asymptomatic, so you don't feel bad unless it's really, really high. So, taking care of your body is very important.
Is there another question? Okay, one last question.
Thank you, Fishy. I just want to ask something because like my brother-in-law last year he had a stroke. So firstly, we are clueless on how to take care of him when he was at home. We have to go and do all those things. So only then I realized that it's very, very important to be aware of like how to take care of a patient once they are discharged from the hospital. And then the other thing I had to say like about calling the ambulance. If ever maybe somebody just got a stroke at home. So for people who live with medication, they can attest to that. Sometimes you call the ambulance at 3, it only arrives at 8. So during that period, how do you help the person so long you're waiting for the ambulance?
Dr. Long did a study on why do patients not get to the hospital in time to get thrombolysis, because there's a sort of a golden hour since the patient arrives at hospital until they get the thrombolysis, the door to needle time is figured out. And taking care of a stroke patient is an enormous responsibility for the whole family. So that's where the secondary prevention comes in. If we see a patient with a stroke, we want to prevent it from happening again. So we must control the blood pressure properly, the diabetes, the cholesterol. He must stop smoking, stop taking alcohol, start to exercise. And then we must also check if there's a heart reason. Some people have atrial fibrillation, that's where the upper chambers of the heart just don't contract properly, and it forms clots, and the clots embolize, so they shoot. So that's something that we can treat with a clot dissolver, like, or a preventative measure like warfarin, where the clots don't form. The other thing that we can do is to check if there's blood vessels that are occluded, and then the vascular surgeons can clean it up or bypass it. It's a specialist field. So those are two things that we to prevent another stroke from happening. If you've already had a stroke, it's a multidisciplinary team that looks after the patient. So there's a doctor, all the nurses are there, you've got an occupational therapist, you've got a physiotherapist, a social worker plays a role, and the psychologist. They all have to, it's an enormous, it's a devastating thing to happen to a person and to their family. There's not an easy answer. How do you treat the patient? If you have a multidisciplinary team, then they speak to the family. If the patient cannot cope, we will need placement. There's not enough places in the Free State to have these patients cared for properly. So it often comes down to the family. Can I ask Dr. Long to just say what were the reasons, what they found in his study, why people did not get thrombolysis?
So our big thing, sorry, is it on? No. So our big thing is we want more and more people to get this treatment that is available to prevent these complications from happening. So the problem is that in our sort of city, basically the amount of alteplase that is being given is very, very low. So it's actually recommended that about 12% of patients who get a stroke should get this treatment. And our statistics show that it's in Bloemfontein, it's 0.5%. So the rate was extremely, extremely low. So my study sort of dealt about trying to find out why is the rate so low. So there's several factors basically that was identified that is playing a role. And one of the biggest roles is that patients are arriving too late at the hospital. And that's where transport factors... Sorry, can you... And now? Oh, yeah. Okay. Did everyone hear that? Okay. So there are several factors that are playing a role, and pre-hospital factors, so factors before getting to the hospital, actually end up being quite a large chunk of this. And that's where transport factors are a problem, where the average time taken from calling an ambulance to arriving at the hospital in the study was about 90 minutes. So that's the average time. So we can just think in those 90 minutes, how many brain cells unfortunately died that we'll never get back. So transport factors are a big problem, but we are trying to address it. So the first thing is to identify the factors and then try and address them. So we are having, or there have been meetings with the emergency medical staff to get them on board and be aware of if they get a call and the patient or the person tells them, I think my dad or my mom is having a stroke, they have to prioritize that call. So I think even you calling the EMS, if you can tell them, my dad, my brother, my sister, my husband is having a stroke, they will know they need to prioritize this call and not go to any of the other calls. So that's something important. But then we saw about 17% of patients actually arrived at the hospital in time to get this treatment, but 16.5% of them didn't get the treatment. So there's several factors in the hospital that are playing a role that we're also trying to address. First of all, if you have a stroke and you arrive at the hospital, you shouldn't go through the normal triage thing of first being seen, getting a color assigned, going and waiting your turn. When you arrive at the hospital, you should be rushed through to the CT scanner, get your CT, and while you're lying on the CT scanner, you should actually be getting your alteplase, just as the CT has occurred. So we're trying to streamline that process of arriving at the hospital, getting your scan, getting your treatment as quick as possible. So we're trying, so there are several factors, but I think awareness is the most important. So now that we're aware and seeing where these factors and the barriers that we've identified, we can address them, and hopefully we'll get that 0.5% rate up a little bit higher, hopefully.
Thank you so much for that, Dr. Long. Okay, so we have concluded with the questions from the floor, so I'm going to close the session. But before I close the session, I just want to say a very huge thank you so much, Dr. Long, Dr. Smith, and Dr. Wenzel. The work that you're doing is intense, and it's very important. Thank you so, so much. And I really trust that the colleagues who are here, you've learned something. By show of hands, have you learned something today? Yes, so yes. So you'll be back again at the next coffee talk, because we keep learning new things here. I don't know if there are any questions, if we are streaming on social media, if there are any questions there before we close. Just one? None? Okay, we're fine. Oh no. Colleagues, with your approval, can I please take one more question, because I don't want anyone to be left behind. Just one more, because I'm seeing a hand right at the back. Yes, no, yes? Thank you, colleagues, you're so kind.
Two questions. Colleagues, the last two questions, then we wrap up the round.
And thank you for the opportunity. I'd like to ask in terms of, I heard Dr. mentioning that oral contraceptives are one of the contributing factors towards stroke. So I wanted to ask, is oral contraceptives the only type of contraceptives, or even what other types of contraceptives do contribute towards stroke? Thank you.
Yes, if you have migraine, the oral contraceptive is no problem. If you don't have migraine with oral, any contraceptive is okay. There are different types of contraceptives. It's not my field of expertise, so you should ask your gynecologist or your general practitioner.
Last question, very last question.
Good afternoon. I just want to ask, in case of the transport, waiting of the transport, we were always told that if you're waiting for emergency transport for somebody who has a stroke, you can use vinegar. Is it a right remedy? Do we still continue with it, or what's happening there?
Okay, it's a good question. If you have a patient and you're waiting for the emergency services and they don't come, the biggest challenge is to get other transport. So if you have a friend or you have your own car, get some help to get this person in the car. If you see it's going to go past 4.5 hours, I would give the patient a Disprin, because that makes a difference in the long run. But the vinegar, there's no help with it.
Thank you so much, Dr. Smith. Alright, I just want to give you a token of appreciation from the library, just to say thank you so much. We really appreciate it. We appreciate your time. And just the work that you're doing, like I said before, it's so important, but it's making a huge impact, a huge difference. Colleagues, please give them a round of applause. That was very warm. And please give yourselves a round of applause for learning something. Alright, colleagues, I'm going to allow you now to leave. If you haven't had any coffee, please feel free to help yourself with coffee at the coffee station over there. And last but not least, I'd just like you to please follow us. If you'd like to know when the coffee talks are, they're on the last Tuesday of every single month. But if you do tend to forget, because I know some of us are forgetful, I can be forgetful sometimes. Please follow us on the UFS_library page on Instagram. We are UFS Library and Information Services on Facebook, for those of you on Facebook. That's where we put all the announcements and where we market all the events that we're going to have. Colleagues, I'll see you again at the next coffee talk. Thank you so much for joining us.